like sunshine, like springtime, like something's in the water and I'm taking a deep dive. I'm feeling so weightless, like I'm gonna make it, and nothing in the universe can take this. I can see it clearly now, nothing gonna bring me down. I got my head held high, I'm on my way, and I'm following the signs to my happy place. I'm walking in the light of a brand new day, and I'm right where I belong in my happy place. I got my head held high, I'm on my way, and I'm following the signs to my happy place. I'm walking in the light of a brand new day, and I'm right where I belong in my happy place. And I'm right where I belong in my happy place. And I'm right where I belong in my happy place.
Welcome to the National University of Singapore Yong Lu Lin School of Medicine Healthy Longevity webinar. After 26 fantastic episodes hosted by Professor Brian Kennedy, I'm moderating today's webinar, and with us is Professor Dr. Nick Guldemond. I will introduce him in a few minutes. I would like you to remind you to use the QA function to send us your questions, because then we can have a very lively discussion after Nick's talk. We are starting today's webinar with a short presentation by Clarissa Lim, and she works in our Center for Healthy Longevity as research assistant, and she is studying the very powerful effect of aerobic and resistance exercise training. And today she will share with us a manuscript that discusses the effects of aging and lifelong aerobic exercise on basal and exercise-induced inflammation in women. Clarissa.
Thank you very much. Hello, everyone. As mentioned, my name is Clarissa, and I am a research assistant at the Center for Healthy Longevity. Last week, my colleague Xin Yi presented a paper exploring the effects of aging and lifelong aerobic exercise on basal and exercise-induced inflammation in men. Today, I will be presenting a paper by the same group who did a parallel investigation in women. From last week's paper, we saw that lifelong aerobic exercise appears to have an anti-inflammatory effect. We also know from other studies that lifelong aerobic exercise is associated with attenuated skeletal muscle mass. However, these studies were conducted in predominantly male population, and the effect of lifelong exercise on muscle inflammation is unexplored in women. Since low muscle mass and frailty are especially common in older women and may be accelerated by age-related inflammation, it is important to find strategies to help preserve skeletal muscle mass and function into old age, especially in women. Resistance exercise training is the most well-recognized strategy in counteracting age-related muscle loss. It helps with muscle growth when the body initiates timely inflammation and resolution of the inflammation after the exercise. This shows the importance of exercise-induced inflammation in skeletal muscle adaptation. However, during aging, the inflammatory response may be dysregulated, and this can affect the body's ability to adapt to exercise, and this can affect muscle health. Based on their study done in men, the group hypothesized that lifelong aerobic training would only partially attenuate age-related increase in inflammation in women. The study included 3 groups of women: young exercisers, YE, old lifelong exercisers, LLE, and old healthy non-exercisers, OH. All groups were subjected to a blood draw and muscle biopsy of the vastus lateralis before and 4 hours after an acute bout of resistance exercise. They then assessed the gene expression of inflammatory markers before and after the exercise. What they found was that lifelong aerobic exercise in women does not affect age-related increase in basal inflammatory levels. This is seen in the older cohorts where LLE and OH combined demonstrated higher IL-6 levels than YE. Besides that, there was no change in the level of anti-inflammatory genes like IL-10 compared to young exercisers. This is surprising since IL-10 and other anti-inflammatory genes were upregulated in lifelong aerobic exercise in men. In response to an acute bout of resistance exercise, it was observed that the overall response was altered by aging in women regardless of their training status. While there was an increase in post-exercise expression of IL-6 in YE, both older groups showed a blunted or perhaps delayed IL-6 response to acute resistance exercise. IL-6 is usually produced in large amounts following exercise, and it plays a role in the body's adaptation to it. The lower response seen in older groups might mean that their body's ability to adapt to exercise could be affected. The older groups also exhibited an increased expression in TNF-alpha, which suggests a more stress-related response to the exercise. Despite this, there were some differences between both older groups, like in the case of IL-1 beta and MCP1, which increased in lifelong exercises compared to free exercise. The effect of this would require further investigation. In all, lifelong aerobic exercise did not appear to protect against age-related increases in muscle inflammation in women. Taken together with the parallel study done in men, there are sex-specific differences in terms of the effect of lifelong exercise on skeletal muscle inflammation. Further studies are needed to understand these differences so as to achieve the optimal strategy for preserving the exercise response in aging women. That's all from me. Thank you very much for your time. And now I hand the time back over to Andrea.
Thank you, Clarissa. Fantastic. And now it's my great pleasure to introduce Professor Nick Guldemond. He is a key expert on digital health and integrated care. And I must say, I haven't seen him, I think, for 10 years now, but I'm following his work. And he is a professor in integrated care and technology at the first Moscow State Medical University. And he is also a senior researcher at the National eHealth Living Lab, and then of the Leiden University Medical Center, where we actually met like 15 years ago. He is holding various consulting roles for governments, NGOs, multinational startups, and so on and so on. And he is also, which is very important in Europe, he is the coordinator of the European Innovation Partnership on Healthy and Active Aging. And he also serves in the Strategic Advisory Group on Aging Societies. So who could be more equipped actually to talk about health systems and how this is related to healthy longevity, which we of course strive for. So Nick, it's my pleasure to have introduced you, and I will give you the floor.
Thank you very much, Andrea, for this very kind introduction. And I feel very flattered, and it's good to see you. And I'm also following your work, and it's quite impressive on all your achievements. Maybe to explain a little bit, my daily work is basically transformation of healthcare systems. And for several countries, healthcare organizations. And it's quite a challenge often because for topics like tackling chronic conditions, we need to have a change in healthcare services, which usually there are system aspects involved in order to make it happen. So this more systemic approach to, let's say, the operational level is often what's quite complex and what I'm trying to help with. And obviously, aging-related conditions, but also prevention, longevity, healthy aging is a key element to make our healthcare system more sustainable. So please let me share my presentation. So first I wanted to talk a little bit about the pressure of health and social care systems. And as you probably know, of course, the pandemic has put a lot of pressure on healthcare systems worldwide, and not only on people with poor economic conditions, situations, but also in the well-developed countries. Obviously, there was a lot of pressure on healthcare systems. But before the pandemic, we already had major challenges with healthcare systems. And one major factor, as you might know, is of course the aging of the population. And the aging of the population does not only have consequences for the healthcare systems and the rise on healthcare needs, but also in economical terms. So one way to express the impact of aging on economies and societies is that what they call the age dependency index, which was for the EU in general, on average was 1 elder person to 4 working people. While the projection for 2050 is that this will dramatically be reduced, in which the Netherlands is relatively lucky with 1 elderly person and 4 working people employed working in the having an occupation and contributing to the economy, while countries like Italy, Spain, Mediterranean countries have even less than 2 people available to contribute to the economy. And you have to think about, well, education, about general sectors contribution, but also all kind of public services running. And for Asia, this is in some countries even less positive. So countries like China, Indonesia, they have huge struggle with in the long term with keeping the economy going with the available workforce. At the same time, we have this problem with that's on the right-hand side. You see a rise on chronic conditions while people are getting older. And here you see a picture of the Lancet about the Scottish population, where you see at the age of 65, there's almost 80% who has 1 or more chronic conditions, comorbidities, which are even more complex and which our current healthcare systems are not able to treat well because of the fragmentation. So if you look to have an example that before the pandemic, we had already problems. And here you see an example from the UK, but the same is for the Netherlands in some of our regions, where you see, for example, with flu outbreaks in winter, that already ambulances were waiting outside, couldn't deliver the patient because all beds were occupied, staff was occupied. People weren't able to, for discharge, going to home because social care services were not equipped to deal with the issues. Staff underpaid, overworked, and this was for several years on row. So if you're looking back from 2015 to this before the pandemic, just before the pandemic, similar problems. So you see it in the US, in many of the developed countries, but it is an indication that our healthcare systems are not equipped to deal with this patient flow to hospitals. So we really have to change. And another summary of this growing pressure of an aging population which leading to a more chronic conditions and comorbidities, while we have lesser resources, both in number of people available to deliver care, as well as financially. This gives an instability of health and social care systems. On top of that, and very, very dramatically being shown in this pandemic, you have these infectious outbreaks like MERS, like simple flu, and we have upcoming infectious diseases like flus, and antimicrobial resistance is a huge problem also on top of this. So we are facing really a huge instability of our current healthcare systems. So we know this already for years, already for more than a decade. We are advocating a transformation of a healthcare system, and we see almost no country is able to anticipate this change. So it gives a little bit a picture, and hopefully this pandemic will give a sort of a tipping point for really thinking about change. But if you look to the responses in the pandemic, the picture is not very hopeful. So also, what's striking me is that the preparedness, pandemic preparedness, is measured by all kind of indicators for different countries. So you see, before the pandemic, the US was indicated as most prepared country for dealing with pandemics. UK, the Netherlands, etc., etc. And what we saw, of course, is that these systems mostly failed. So it gives another picture that the measures we use and indicators, and often these countries are boasting about how well prepared and wonderful healthcare system they have. Well, in reality, it's something different. So if you look to, of course, there were good examples of leadership and countries who were dealing with the pandemic, but also for major developed countries really failing in their approach on dealing with issues. And of course, a pandemic has a different dynamic than a gradually rise on healthcare challenges because of aging and chronic conditions, but it goes together. It says something about how leadership, policy, and management deals with these type of issues. So it's a sign that we really have to go for a different type of action and different kind of leadership and policy in order to make it happen also for the chronic conditions related to aging. So what kind of opportunities and challenges do we have? So here you see a picture on the left-hand side, which is illustrating the traditional healthcare system, monodisciplinary, a dominant role of institution of medical care, and not so much the community care and local facilities being part of a sort of more integrated approach. While on the right-hand side, you see this more model we use, from which we know this will be more sustainable. This is better able to deal with complex conditions, is better able to deal with or to provide prevention. Is more this community-based approach with local health centers, and the less dominant role of the biomedical curative approach of hospitals, which we had over the last century, more or less. So we have to make this change happen. And another thing I want to point to is, so basically in general for health and welfare of people, is a clinical biomedical approach is not so very dominant. There are a lot of other factors who influence a general welfare and health of population. And usually these are quite economic related, opportunities for work, education, education is a very important factor in also in prevention, in a more healthier generation, also for the future. And health behavior is a major factor. So if you really look into the, let's say, the biomedical interventions, this role is relatively small compared to what we can achieve with improving health behavior and improving the socio-economic situation for people in general. So working conditions, prevention, healthy living, healthy aging are the key elements in order to make our society more sustainable. And not only for healthcare, but also in general terms for economy and happiness of people. And another indication for this idea that this biomedical approach, of course, it's brought us in the last century a lot of achievements and progress in medicine, an improvement of quality of life, and etc. But it's also a very cost-intensive way of improving health to people. And there's a lot of marketing and boasting about what, let's say, the life science approach could bring to the health of people and improvement of healthcare systems. But healthy behavior, like better food, less stress, more exercise, is much cheaper. It's less prone to side effects. It doesn't medicalize problems of people, or even people who might have a sort of disease in the future with all this prognostic screening based on genomes. So exercise and healthy living is really a key factor if we want to make this healthy approach, healthy aging, longevity more effective. On top of that, another indication is the costs which are related to what is called innovation in healthcare. It's only contributing to the expensive in a healthcare system. So this is an example of the Netherlands, where you see the cost projected from 2015 to 2040, and you see the contribution of aging. That's 1/3 demographical change over time. So that's relatively less compared to the cost rise, which is related to development of new medication, the so-called technological innovation. And it's maybe also good to mention that all this innovation and medication doesn't necessarily contribute to better health outcomes. And so we have many indications that this focus on biomedical solutions will only drag people into the healthcare system, and it will also contribute to extra sort of diagnosis and screening and treatments, and also side effects. So you see only in very few occasions that these sort of improvements and innovations are cost effective. So to conclude my presentation, so I think the lessons learned is that, yes, we should invest in health and social care systems for the sake of prevention and have more this community-based approach. So we should support professionals, but also people in self-sufficiency, self-management. Management skills for within the system is important because we have highly fragmented system. A digital infrastructure might be important, but not only focusing on single apps and single solutions, but more on how we can make how we can use digital solution to make it more efficient. Community focus, prevention, healthy aging, what we see in many countries is that a strategy, a clear vision, a concrete roadmap is lacking, and also a coordination for this transformation. As what we see in the Netherlands, with all the resources we have, we are not able to make very successful changes in the healthcare system. Therefore, leadership is also a key element, as what we saw also in the pandemics. Well, female leadership is proven to be better than male leadership. And international collaboration is key also in this, could say, sort of global challenge. The same with climate, environment, and energy, health, and healthy population, access for all is also an international issue. Thank you very much for your attention.
Thank you, Nick. Wonderful. Maybe before starting talking about a little bit about the COVID, how disruptive COVID really was and is for healthcare systems, can you tell us a little bit how you think we should measure health outcomes? So what is a better health outcome? How do you normally measure it in healthcare systems?
Well, I think that there's usually the traditional indicators like length of stay, quality of life, etc., which is okay. But I find it quite interesting that this importance of patient experience and patient measured outcomes. They are a way to understand more about the needs and the success of the approach for people. What does it mean for people? And obviously, blood glucose for a person might be important, but eventually it's like, I want to do shopping. I want to have energy for going to work. It's much more meaningful. So I think this is an important trend. Although I should say, and that's also, I think, a message for academics, because we saw a lot of activities in indicators related to health outcomes the last years. But they are then so focused on the specific indicators, while they're forgetting the sort of process indicators which you need for improvement of the system. So also here, a holistic approach to both process indicators and outcome indicators are probably the way to go forward. And not too much, I would say, but just a few key indicators which help patients, which help professionals and also policymakers in order to make a real efficient system.
Yeah, I think this is very interesting because you're talking about very specific health indicators which are specific for certain domains of the healthcare, like length of stay, for the inpatient situation. So, but you also showed us very nicely that I think we have to think a little bit more disruptive and think about trajectories of individuals who want to become healthy again. So what would you advise, or what do you think about of key indicators we could use, we could actually apply during the trajectory of the patient, or maybe not even a patient, but that individual?
Yeah, no, that's really an important point, Andrea. And I would say it's also important for the redesign and transformation of the system, because eventually, when thinking about changing healthcare services, you have to go back to, okay, what are the needs of the people? What's going wrong in the current system? What goes wrong in the current system? Throughout the whole process, from no complaints to early screening, diagnosis, treatment, navigation through the system, intervention, monitoring, rehabilitation. So the whole process, you want to know, okay, how can we improve this process through the patient's eyes and experience? So it starts all with looking at the patient needs and the experience throughout the process. And that gives a direction, okay, this is what we should improve. And of course, you have different perspectives, like the sort of interaction with professionals, the exchange of information during the process. So data and technology comes also along this process. But this process approach for redesign, and in the process looking at, okay, what are the key factors to improve, is one way to use information from patients along with the biomedical indicators. I should say, so first look at the patient needs throughout the process. They give the sort of key indicators or factors for change. Mm-hmm. And then if you compare the sort of existing situation with the improved situation, and you can look at the spectrum of indicators in the outcome, which obviously have to show, okay, diabetes is better managed, but also in terms of maybe social activities and adherence and happiness. There can be a set of indicators more from a patient experience, which also could be a sort of indication on, okay, how well we are managing our people in keeping more healthy.
Yeah, but still then we have to, I think, see how we are measuring that through the systems. And I think that's a challenge. Do you agree?
Yeah, so I think so. There are numerous indicators. So we have enough indicators. Yeah. So I think one important thing to do is aligning those indicators with the sort of patient journey or the care process. I think what's missing in the current debate is much on how the different phases, how this process, where there are the key elements which are failing. Like in oncology, you see often that the lack of adequate diagnosis gives anxiety in patients and uncertainty feelings. So this is not so much often taken in consideration in the care process. And so it's not only about having these diagnostic techniques available, but also how to deal with more like experiences, insecurities, uncertainties for patients, for example. So aligning existing indicators and include also more this patient-related aspects, and not only related to the outcome, I think is the way to go forward.
Yeah. Before coming to the preventative part, which is of course our core business here at the Center for Health and Longevity, I would really like to pick a little bit your brain about COVID, because COVID changed so much, at least in Melbourne when I was on the wards, the way we are caring for inpatients at least. I would like to know how sustainable these changes due to COVID really are, in your opinion.
Well, I'm an optimist, really. I'm often very critical on things, but that's more, I want to raise a discussion. So currently I'm involved in many discussions with governments, WHO, etc., on how to look forward and what can we do differently. And I would say, if I'm looking to also the Netherlands, so there is not much indication for being very optimistic that our policy leaders are now totally understand the message and that they have to do things differently. Maybe in some countries, we see some of the Eastern European countries, we see some, I think, good discussions. So I think we need something extra. And again, I'm coming back to, it's so important that we need this vision for the future, in which prevention, also healthy aging, longevity, play a key role. So that's first. So the vision has to be clear. And I think at WHO, at USO, all these big NGO organizations, they know it. It's already there. But if you look into the government plans, the government strategy and messages, it's still a bit lacking. And if they are present, then usually the sort of concrete actions and measures are lacking, because you need a system change, and this is a huge risk for politicians. And therefore, I think it's important that healthcare professionals stepping in. Because, usually or often you see that professionals are very focusing on their work and the importance of their specific issues and making sure that things are running smoothly in primary care or hospital. But we have been stepping up because also for the benefit or for the interest of ourselves in keeping the work going with increasing pressure, lesser resources, we have to show to the politicians this is not the way to go forward. And we can help. We know how to build a sustainable model, but I think we could do a better job in this. And for example, in the Netherlands, the hospital organization, the medical professionals, the medical specialists, they have a vision, but they usually apply only to their own type of work. Primary care, the same. Social care, also the same. So this more like binding things, joining up together and speak up, okay, this is what we want to do. These are the typical roles we have to play in more better integrated services. We need to have a stronger voice. And I think you are a wonderful example also of this approach.
So if you look back to COVID, I think there's so much disruption, bringing technology in from one day to another, like having telehealth in so many countries. So many physicians now and nursing staff, allied health professionals use that. Do you think, I think personally it's a very good thing because we need that disruptive moment, which is the pandemic, to introduce change. So do you think that this is sustainable? And if yes, how do we make it, or if no, how do we make it sustainable before we go into the prevention part?
Yeah, I think digital has huge opportunities. And also, yeah, like you said, thanks to COVID, the sort of digital interaction increased in many countries and more professionally, or it was just by WhatsApp or text messages. And so you saw all kind of sort of digital innovation taking place, and the uptake was like we have never seen before. So that's good, and we should capitalize on that. But so the digital interaction is not the only thing we need to make healthcare sustainable, because like healthcare, it's a sort of process with many actions in the time, not only interaction with the patient, but also between professionals, if you want to do it in a more integrated way, and this in a very efficient way. So what you saw and what was mostly, let's say, promoted or cheered about was this single solution for interaction, which we need. But in order to think more about sustainability, we have to think about digital infrastructures, by which you can seamlessly interact with colleagues, with patients. You need all kind of other information in the operational process, and having information accessible from primary care, from a hospital, maybe from social care. Think about patients with schizophrenia living in communities. And this requires a lot of actors in the process, which have to be sort of real-time informed about what's going on, what we should do next, etc. So this infrastructure is very different from a single app or a single solution. So that also it needs a different type of approach. Most countries has lacking this sort of neglected this type of infrastructure, including the Netherlands. So we have a very fragmented we're still faxing for between hospitals. So again, it's okay, but we need extra.
Look, this is, yeah. Look, we are still in the fax space. But which country we can really learn from? So which one really wins the gold medal in integration of healthcare systems and also technological ways of communication with electronic medical records? So what is really the example on Earth? Tell us.
Well, I think there's no single country which is fully integrated and seamless sort of digital solutions for health and social care.
Okay.
But there are a lot of good practices. So I think Singapore is a wonderful example where you have relatively for different dimension in the healthcare system, you have the information well at hand. But take, for example, some regions in Spain, like the Basque Country or Catalonia. You have some regions in Sweden. So there are pockets where they do well. And surprisingly, I'm working a lot in Eastern Europe. So Ukraine has a wonderful vision and setup for a digital platform. The same goes for Armenia. If you look to Moscow city center, and you see how the services are provided online through an app, and making health and social care really accessible, it's also a very good example. And not the least, of course, China. I think there are the major platforms who show real efficiency and benefit, but also with some remarks. But yeah, I think this is to look at and to learn from.
So before really giving the floor to Shara Kapimping, who is actually our research assistant, and capturing now the Q&A questions from the audience, Nick, I really would like to learn from you. You are saying that we should invest in a higher socioeconomic class, and we should invest in education, we should invest in lifestyle, and we should not invest in doctors because that will not really gain much more healthy longevity. So how do we do that? What's your secret, or what did you learn from your long history of working with lots of governments?
Yeah, well, first I wanted to say we have to invest in doctors, but I think we should teach them differently. So that's first. So our curricula are quite traditional, and to make changes in curricula, like for the Netherlands, it takes maybe 10 years. So we don't have this time. So we have to really think about, okay, how can we prepare for the future doctor? And Leiden University Medical Center is working, for example, in The Hague with sort of models for future doctors, primary care doctors. No, but primary care is a major source for investment. And the Netherlands is one of the, I think, together with Norway or Canada, or Australia, where primary care is well equipped and well functioning. What we need there is the addition of a better digital system to support them. But in most, let's say, countries, is social care and primary care are the key aspects to invest in. And these are also the recommendation by the OECD and WHO. And to go beyond that, if you're really looking from, okay, we want to make a more healthier, happier, sustainable society, the approach from policymakers is you have to develop a sort of cross-ministerial approach to make it happen. You need social affairs, you need healthcare, you need maybe changes in rules, regulation, data legislation, for example. So this is a major challenge for ministers and policymakers because it touches upon their sort of responsibilities, and they need to collaborate. And it's also a big risk, and usually these policymakers don't want to avoid it. So you really need strong leadership in order to make it happen. But yeah, I think New Zealand is a very good example of how to go forward, I think, with a good vision, good communication, and with, at the same time, very concrete actions. So we can look at some examples, some countries who are doing quite well, but still, you see the sort of inertia of the traditional medical system, because this is also about interest of healthcare hospitals, for example, institutions, but also academics in thinking more, okay, how can we contribute to a more resilient society? And not only about publication indexes or the funding for your own research group. And so these are balancing the interests and developing a sort of new, okay, what are the opportunities? How can we make a shared benefit of this? Is a major effort. And yeah, we're making progress, but it's going far too slow. So I think doctors step up and join this movement.
So it's a relief that we are still needed. So that's good. For the ones who don't know me, I'm a specialist in internal medicine. So, but I really like your point that we should really focus on primary care, because that's the basis of having that attention to have that early detection of diseases and especially of prevention. I think primary care should really step up to prevent age-related diseases. But let's see, Shara, do we have questions from the audience?
Hi, thank you, Prof. Andrea. So yes, we do have quite a number of questions from the public. But first I would like to thank Prof. Guldemond for that very insightful sharing. So just a little bit of background to Singapore, right? So we have an estimated about 15% of our population that are aged 65 years and older. And we are actually expecting this number to increase to 25% by 2030, which is not really is not that far from like today. So, and we also know that in 2050, at least half of our audiences will be joining the ranks of the 65 years and older. So this discussion could not have come at a better time. And I think the number of questions that we have received today is certainly a testament to the importance of this topic. So I will try to go through as many of the questions as I can. So to start off, I think a lot of our audiences are scientists and medical professionals. So a lot of them are very curious as to how we can effectively convince government around the world that treating biological mechanisms of aging may be a better approach as compared to going about individual age-related diseases.
Yes, well, if you look to how evidence has changed the sort of thinking in policymakers, and although they're all claiming, yeah, we work evidence-based, we're really looking at the evidence, it didn't prove to be very effective in a change of policies in different actions. So by adding more evidence probably won't help. And probably it's the sort of message that we need to change. And in line with what I said earlier, I think it will be more important to describe the bigger picture and be clear about what the sort of biomedical approach could add to the overall, let's say, effect of making a system change happen. And one of the problems, I think, also with credibility in science is that we currently have a lot of scientists or professors who are so focusing on getting the funding for their research groups or research. And that also, you could say they are boasting rather than having a sort of balanced argument about, okay, this is potentially my role, this is how we could contribute, and these are the upsides and downsides. So more a realistic debate probably will be more effective. And also, I think an important element to make the steps to make it concrete. Because presenting a paper with wonderful results is not sufficient. We have to also do something in the translation in, okay, how can we make it work in practice?
Do you think that policymakers do enough, know enough about mechanisms of healthy aging? So are we there yet that the message is clear that we could prevent age-related diseases because we're understanding the mechanisms of aging?
Well, no, I don't think so. Because you have these more fundamental mechanisms. And obviously, like you can tell these people on, okay, what are the sort of approaches, how to intervene in these mechanisms. But we need to have a sort of a multi-level approach. So we see how the biomedical approach is one angle, but also we need these more like exercise, societal prevention, community, public health sort of issues, and the even broader picture on how to build resilient communities and better welfare in terms of economic sort of factors and education. So I think bringing this more holistic perspective with the different elements in a sort of easy to understand, realistic way, I think probably will work better. And I think this is also the discussion we need in many governments and organizations.
All right, thank you so much for that, Prof Guldemon. So we actually have a question all the way from Curacao, from Soraya. So she's very curious about what type of projects and programs will we need to prioritize to go from biomedical healthcare system to the social healthcare system.
That's very nice. So I during the pandemic, I was active in Curacao, where I looked at the healthcare system and how to improve it. So I think for Curacao, it's a relatively small population, about 160,000 people. There are good ingredients. So there's a well-equipped hospital, a bit too big, maybe, but there are very good primary care initiatives. I think there's a strong social community infrastructure. So there are many elements to build a more holistic, integrated approach. I think in many other healthcare systems, the problem in Curacao is, of course, about vested interests and also the finance within the system, which need to be changed. So again, there is the approach to talk with all the stakeholders on, okay, how can we improve health of people in general, including prevention, and how we can make it work. What are the tasks, responsibilities, who does what? And that's the first step. And in the end, okay, we can talk about how to distribute money and etc. So I think Curacao has a lot to offer, and there are many opportunities to build from the existing ingredients. But yeah, so this change approach with the different stakeholders and to have this shared understanding, okay, this we should do for the different populations, from healthy to chronically ill with comorbidities, is the sort of way to go.
So building on that, what do you think with our future, how would the integrative medicine be part of like contribution to healthy longevity?
I think so this primary care-based sort of approaches to healthy aging and longevity is that there's an opportunity to do what we know, what we should do with prevention and general public health measures, but complement this with more specific interventions and mechanisms, what we learned from sort of biomedical perspective. So this sort of community approach, multifactorial intervention, so to say, I think that would be wonderful if we can establish this in community health centers, where you can make these solutions be better accessible and not only, let's say, medicalize in a hospital setting. So I think that's the way to go. And we still have to develop the models for this. But I think, yeah, Singapore is one of the sort of countries, because of the infrastructure and all what's already there, to make this an example in Asia.
I would also like to ask as well, if let's say we were to effectively implement healthy longevity measures, what kind of measurable items should we look out for to determine if the approach to healthy longevity have been effective?
Well, I wouldn't say there's one single indicator which can, well, maybe quality of life or happiness, but usually we have to look at a sort of spectrum where you look at mental health aspects, at daily activities, about including also key biomedical indicators. So probably a set of, let's say, 10 indicators would be sufficient to look at the general health of people and healthy aging.
May I step in here? Would one of the key indicators of a novel key indicator be the incidence of the first age-related disease in the population, which could be quite measurable by general physicians, for example, by GPs?
Yeah, no, sure. And I should say we have a numerous, let's say, measures and indicators for aging, and we have done a lot of research on this. So I think, yes, that could work. Additionally, it would be nice to make a reference to sort of population level or community level. So the geographical context included, because also the incidence and how it's related to the, let's say, context of the individual, like the family social structure, but also how is this related to the situation in the city or the village, pollution, economics. So I think this more elaborative approach, and also because we have increasingly this access to data from localities, which might be relevant into, okay, what kind of approach we should follow.
Yeah. Okay, so it's very clear, because this was the last question for you, Nick, that we should really cure our healthcare system. So how can this healthcare system cure us if it's maybe a little bit sick? But I think you really showed that very nicely, that we need a more holistic approach, and we have to reduce barriers between the acute and the subacute and the community settings. And maybe also, and it's a pity that we couldn't discuss it, leave the responsibility also for health in the hands of everybody. But that's another discussion and maybe for another time. May I thank you, Nick, for this wonderful presentation. And I would remind everybody to leave some comments or feedback, if you have them, in the panelist and all attendees function. And also, I would remind you to register for our next webinar. And that's also a very special webinar I will host together with Professor Charlotte Suetta from Copenhagen, Denmark. And she will talk about muscle and aging and how we can regain muscle health while we are aging, or even prevent that we are losing muscle mass, etc. And muscle has not been approached yet in our seminars. So thank you again, Nick, and we will close this webinar with a very important message from a 100-year-old lady. I would like you to thank for your attendance, and I wish you a very nice evening or morning wherever you are on Earth. Thank you. Take care.
The thing that I would suggest, as I did to a girl yesterday, do your best no matter what you are doing, and thank God that you can do it. Most of us, a lot of us I should say here, are not too far behind me.
She's making friends, making friends.
How did I make it this far? I would say right now, this kind of thing in which people love each other, talk to each other, help each other, and just anything. Don't hold a grudge of any kind. Love people, even if they don't love you.
I'm feeling like sunshine, like springtime, like something's in the water and I'm taking a deep dive. I'm feeling so weightless, like I'm gonna make it, and nothing in the universe can take this. I can see it clearly now. Nothing gonna bring me down.